Hello, my name is Graeme Eisenhofer. I've been working on catecholamines and catecholamine pathways for 40 years. In particular, most recently, over the last 20 years, also diagnosis of Pheochromocytoma with metanephrines. This is a test that I developed with Jacques Lenders at the NIH over 25 years ago, and it's now pretty much in routine practice. I'm working currently at the University Hospital Dresden, and I'll move right into my presentation. To start with, plasma metanephrines, plural. These include normetanephrine and metanephrine singular, respective O-methylated metabolites of norepinephrine and epinephrine. The O-methylated metabolites of dopamine is methoxytyramine, which has not been traditionally included in tests of metanephrines. In plasma, the three O-methylated metabolites are commonly measured as free metabolites. This differs from urine, where measurements are commonly performed after an acid hydrolysis step, which results in conversion of the sulfate conjugated metabolites to the free metabolites. Now, this is important to consider since the free and sulfate conjugated metabolites have different sources. The free metabolites are formed in chromaffin cells and extraneuronal tissues and are rapidly cleared from the circulation by the same transporters responsible for the clearance of catecholamines. On the other hand, the sulfate conjugated metabolites are formed in the gastrointestinal tract and have a much slower circulatory clearance by the kidneys. So they represent the main metabolites excreted in urine. These differences impact the utility of plasma-free versus urinary deconjugated metabolites for diagnosis of catecholamine-producing tumours, as shown here for patients with and without tumours, and according to relative increases above upper cutoffs. This is shown here for metanephrine on the left, normetanephrine in the middle, and methoxytyramine on the right. And you'll notice there's actually no difference in the diagnostic utility of plasma-free versus urinary metanephrine, that's the metabolite of epinephrine, for which a little over half of all patients with disease show increases in this particular metabolite. Now, this is because almost all metanephrine produced in the body, that's the metabolite of epinephrine, is produced in adrenal chromaffin cells, where almost all the epinephrine is also produced. Now, this contrasts with normetanephrine and methoxytyramine, for which substantial amounts are produced in the gut and then converted there to the sulfate conjugated metabolites. So this dilutes the signal strength of the sulfate or the deconjugated metabolites in urine. Consequently, the diagnostic signal strength is stronger for the free than the urinary metabolites, and this is particularly so for methoxytyramine, which for urine has no value as a biomarker of tumoral dopamine production. Now, the resulting diagnostic utility of plasma versus urinary tests differ according to the reason for testing. For patients tested due to signs and symptoms of catecholamine excess, either test will identify patients with the tumours, since these tumours will be producing either or both norepinephrine and epinephrine in sufficient quantities to elicit those signs and symptoms and a positive signal for normetanephrine and metanephrine. Nevertheless, the urinary test has lower specificity than the plasma test, i.e. more false positives. On the other hand, for patients at higher risk for a tumour due to an incidentaloma, hereditary predisposition, or previous disease, the plasma test offers superior sensitivity. And this is because these patients tend to have smaller tumours or tumours that produce only dopamine, for which the superior signal strength of the plasma test offers advantages. So, in summary, the free metabolites measured in plasma have different sources than the sulfate conjugated metabolites commonly measured in urine. These different sources vary for each metabolite, which then differentially impacts the diagnostic performance of each metabolite. Performance is poorest for urinary deconjugated methylcytoma, very little of which is formed from the circulating free metabolite, and that thereby renders this urinary measurement of negligible value. Norepinephrine is the metabolite most consistently elevated in patients with catecholamine-producing tumours, though less so for measurements than urinary deconjugated than plasma-free metabolite. Now, either test panel offers sufficient sensitivity to detect disease in patients tested due to signs and symptoms, but the urine test is associated with higher rates of false positives than the plasma test. On the other hand, for patients screened due to an incidentalloma, genetic risk, previous history of a tumour, the plasma test more reliably detects disease than the urinary test. And thank you, that's it.